Hello everyone, welcome to my YouTube channel. This is Sir Steven, and for this medical histology laboratory lecture series, we will discuss dysplasia and neoplasia. In the previous chapter, we considered cell adaptations to a variety of stimuli resulting in alterations in their pattern of growth whilst still achieving full differentiation or maturation. Occasionally, cells have an increased rate of division such that they do not have time to reach complete maturation or with full development of cytoplasmic specialization before another cycle of cell division supervenes. This leads to a population of cells that are structurally abnormal, having a high nuclear to cytoplasmic ratio with large nuclei containing abundant dark staining chromatin and prominent, occasionally multiple nucleoli. These nuclear changes are associated with the evidence of incomplete maturation of the cytoplasm, which may be lacking in the specialized structures normally seen in that cell type, such as your mucin vacuoles or surface cilia. This is called a failure of differentiation, and the cells are said to show atypia. In addition to neoplasia, there are several other terms that we need to review that refers to abnormal cell growth. These include the following: hyperplasia, referring to an abnormal increase in the number of cells which are in a normal component of the tissue are arranged in a normal fashion with subsequent enlargement of the affected part. Hypertrophy refers to an abnormal increase in the size of each cell. For example, the increase in cell size of your cardiac muscle. Metaplasia refers to the replacement of one mature cell type with another mature cell type. For example, squamous metaplasia of the respiratory columnar epithelium, as evidenced by the metaplastic cough of a smoker. Dysplasia refers to the replacement of one mature cell type with a less mature cell type. For example, the dysplasia of your cervix epithelium. Hyperplasia, metaplasia, and dysplasia are reversible because they are results of a reversible stimulus. Neoplasia is irreversible because it is autonomous. Dysplasia is a morphological feature which are characterized by increased cell proliferation with incomplete maturation of cells. It occurs most commonly at the uterine cervix and in the skin. In your A, it illustrates a normal stratified squamous epithelium from the cervix. Cell proliferation is confined to the basal layer in letter B, where the cells are small, uniform, and darkly stained. As the cell mature towards the surface, their cytoplasm expands and become more eosinophilic. Near the surface, the cells become progressively flattened. The ratio of nucleus to cytoplasm diminishes as the cells pass from the basal to surface layers. In contrast, letter B will show you a dysplastic cervical epithelium, where there is a disruption of the normal orderly maturation sequence. Cells in all layers now exhibit, as you can see, larger than normal nuclei, some of with prominent nucleoli. The mitotic figures may be seen in letter M, well above the basal layer. The nuclei of the cells are more variable in shape and size than normal, and they exhibit pleomorphism. And the nuclear to cytoplasmic ratio is greater than the normal. It is the presence of such surface cells with large nuclei that alerts the cytologist to underlying dysplasia in a cervical smear. In C and letter D, demonstrating similar features in normal and dysplastic skin, respectively. Note that the normal cell stratification is disrupted in the dysplastic specimen by cells with large, darkly staining nuclei and multinucleated cells in letter N, extending into the middle strata. In addition, a disturbed pattern of maturation also is reflected in the development of a thick layer of keratin which contains purple-stained nuclear remnants, or the term parakeratosis. It is this keratin layer that becomes clinically evident as thickening and scaling of the skin. Mitotic figures are also apparent above the basal layers. Before I move forward, this is a very good discussion, or a very important discussion that has importance and relevance to pathology and histology, screening and pathology. It is a very vital part of disease prevention, and it involves assessing a subset of population for a disease condition using a relatively non-invasive test. It allows early detection and treatment and therefore improves survival rates. There are diseases and conditions, screening tests, and diagnostic tests for cervical cancer, breast cancer, colorectal cancer, and prostate cancer. Moving forward, we've learned the molecular basis of cancer, just a review about carcinogenesis. Transformation from normally functioning and growing cells to cancer is called carcinogenesis and is regarded as a complex multi-step process involving acquisition of genetic mutations, failure of normal DNA repair mechanisms, and reduced apoptosis, along with developing the capacity for invasion and metastasis. These are the inherited cancer syndromes in their genes, their chemical agents, and their association of diseases, infections, the agents, and their associations. Moving forward, the term carcinoma in situ, as what you've seen in this figure, is used when an epithelial tissue shows the cytological and histological features of carcinoma, both in architectural and cytological abnormalities such as cell crowding, pleomorphism, increase in abnormal mitotic activity, which may involve the full thickness of the epithelium, but there is no evidence that the basement membrane bounding of the abnormal epithelial tissue has been breached, and there is no enroachment of atypical cells into the underlying stroma, and this process is shown in this figure. In neoplasms, we have a summary of the features of neoplasms based on their behavior for benign and malignant, and histology. So basically, when we differentiate benign, it resembles cell of origin. They are well differentiated. There are few mitosis, normal or slight increase in ratio of nucleus to cytoplasm, and cells are uniform throughout the tumor. Whereas for malignant, they may show failure of cell differentiation. They have many mitoses, some of which are abnormal forms. There are high nuclear to cytoplasmic ratio, and cells vary in shape and sizes as they practice cell pleomorphism, and or the nuclei vary in shape and size for nuclear pleomorphism. In addition, they have also paraneoplastic syndromes, where in direct or local invasion and metastatic spread, cancers may give rise to distant symptoms and or signs through two main mechanisms. The first one is an immune response to the malignancy of producing antibodies to tumor cells, which cross-react with normal cells. In many cases, the antibodies may target normal neurons, producing well-characterized complex neurological presentations, and also with the release of cytokines or hormones by the malignant cells, such as your ectopic adrenocorticotropic hormones, which may be released by a lot of cancers, including the pulmonary carcinoma. In the nomenclature of your epithelial tumors, we name them according to their tissue of origin. Let's say, for example, surface epithelium. We have types of surface epithelia: squamous, glandular, or columnar, and transitional, and also with solid glandular epithelium in these solid organs such as your thyroid, your kidney, and your liver. For connective tissue tumors, it is different according to their tissue of origin. We have fibrous tissue, the bone, the cartilage, adipose, smooth muscle, skeletal muscle, and your blood vessels. And they are named for the benign and malignant. This is squamous cell carcinoma. In letter A, it is well differentiated in high power, and this B is poorly differentiated in high power. Squamous cell carcinoma may arise in any site of native stratified squamous epithelium, for example, your skin, your esophagus, or your tongue. They may also arise in stratified squamous epithelium that is formed by the process of metaplasia, for example, in the bronchus or urinary bladder. The degree of differentiation varies widely. Well-differentiated tumors, as seen in letter A, have cytological features similar to the prickle cell layer of normal stratified squamous epithelium. The cells are large and slightly fusiform in shape, and the nuclei exhibit a moderate degree of pleomorphism. In contrast, the poorly differentiated squamous carcinomas in B lose most of their resemblance to normal prickle cells, and they have a high nuclear to cytoplasmic ratio. Keratin pearl formation is not seen, although individual dyskeratotic cells and letter D may be present. KP stands for keratin pearls, N are the nests, D is for dyskeratotic cells, and yeah, that's it. Next is your transitional cell, or we call it urothelial carcinoma. Letter A is a low grade or grade 1 in low power, and B, that's a high grade or grade 3 in high power. These tumors arise almost exclusively from native transitional epithelium in the urinary tract. In letter A, it shows a typical papillary tumor resembling a normal urothelium but with slight nuclear pleomorphism and minimal evidence of mitotic activity. Letter B, it shows a high-grade solid tumor from a bladder wall. Note that the nests of highly pleomorphic tumor cells in letter D are invading between the bundles of your smooth muscles in letter M. Tumor markers are the substances which are produced by your cancer cells, usually in high amounts, and can be detected by biochemical assays of the blood or the urine. These markers are also produced by the normal cells, usually at lower levels, and also by benign conditions. Therefore, these markers are not particularly sensitive or specific. They can be used for cancer screening, monitoring response to therapy, and detecting recurrent diseases. So below, we have here hormones and their markers and the tumors associated with it, proteins, and the molecular markers. This is colonic adenocarcinoma. In letter A, it's well differentiated in medium power. Letter B is poorly differentiated in high power. Carcinomas that derive from the surface of your glandular epithelium, such as your colon and stomach, tend to exhibit a glandular pattern of growth and are known as adenocarcinomas. The same is true of carcinomas arising in solid glandular tissue, such as your kidney, your breast, and your prostate, and of the tumors of the liver, which in embryological terms develops as an outgrowth of primitive gut epithelium. In letter A, it illustrates a typical well-differentiated colonic adenocarcinoma. Although it is a carcinoma, it is still exhibiting a glandular pattern in letter G, which is reminiscent of a normal colon. The cell nuclei are, however, hyperchromatic, with a high nuclear to cytoplasmic ratio, and a numerous mitosis in letter M are seen. Unlike the normal colon, the glandular pattern is irregular and there is little evidence of mucin secretion. Poorly differentiated adenocarcinomas in letter B display a minimal tendency to form a glandular pattern, and these cells are extremely pleomorphic. The only evidence of glandular origin is the presence of occasional cells with secretory vacuoles in V containing mucin. In signet ring cell carcinoma in letter C, the tendency to produce mucin-filled cytoplasmic vacuoles is greatly exaggerated, such that the majority of cells have their nuclei in letter N pushed to one side by a mucin-filled vacuole. This pattern is much more common in the stomach than in the colon. In contrast, in a mucinous carcinoma, as shown in D, excessive secretion of mucin and Mu results in a so-called mucin lakes in which small nests of tumor cells are found. This pattern of adenocarcinoma is not uncommon in the colon and is also well recognized in the breast. Sarcoma in letter A, that's leiomyosarcoma in high power, and letter B is a Ewing sarcoma in high power. Sarcomas are malignant tumors derived from connective tissues, including your adipose tissue, your bone, cartilage, and your smooth muscle. Many sarcomas resemble the tissue of origin either cytologically, structurally, or by producing characteristic ECM materials such as your collagen and the ground substance. In letter A, it shows an example of a uterine leiomyosarcoma, which is a sarcoma derived from smooth muscle. These tumor cells are spindle-shaped, as what you've seen, and resemble a normal smooth muscle cell. In letter B, it shows a typical Ewing sarcoma. The malignant tumor typically arises in the medullary cavity of long or flat bones in children, though the cell of origin is unknown. As shown here, the tumors consisting of sheets of small round cells with a glycogen-rich cytoplasm. It is very clear on the standard H&E staining. Lymphoma in high power, shown you in this slide. Lymphomas are solid tumors which are derived from the cells of the lymphoid system. The majority of these are arising in lymphoid organs, such as your lymph nodes, your like spleen and bone marrow, but may spread to other tissues, particularly the skin, the liver, and your central nervous system. Histologically, the lymphomas are consisting of sheets of lymphoid cells that are arranged either diffusely or in a follicular pattern. In this figure, it illustrates a diffuse large B-cell lymphoma, the DLBCL, which are characterized by sheets of large atypical lymphoid cells. DLBCL is the commonest type of your high-grade lymphoma. Melanoma and high power are malignant tumors of melanocytes, most often arising in a sun-exposed skin, though examples arising in sites not traditionally associated with sun exposure do occur, such as your bowel and dura. Clinically, melanomas appear as irregular, variably pigmented, raised or flat lesions that may be prone to bleeding. In this example, the tumor cells are large, irregularly shaped, and have an abundant cytoplasmic melanin pigment. Unfortunately, this typical appearance may not always be apparent, particularly in metastatic tumor, for example, in a lymph node specimen where the primary may be unknown. Teratomas and medium power. Teratomas are tumors derived from germ cells and most commonly arise in the testes or the ovary. The tumors contain neoplastic tissues which are derived from all of the three germ layers like the endoderm, mesoderm, and the ectoderm, including your neuroectoderm, and thus it can contain tissues as diverse as skin, feet, thyroid, brain, and muscle. The tumors range from benign to highly malignant. This is a benign teratoma of the ovary is shown in this micrograph. Epidermis type epithelium including the hair as seen here. This is the degrees of tumor differentiation in colon. In letter A, it's normal mucosa and high power. Letter B is benign neoplasm and high power. Note the similarity between your normal colonic mucosa in letter A and a benign neoplasm, which is a tubular adenoma in letter B. In both cases, the epithelial cells are tall in letter E, columnar and regular in form. The main points of difference are that the cells of the benign neoplasm, which are containing less mucin and Mu, and their nuclei are larger and more crowded. This is the cells of the well-differentiated malignant neoplasm in C, and also tall and columnar, but the nuclei are more irregular in modes of spread. You will see here in letter D that the cells bear little resemblance to the tissue of origin and are arranged haphazardly. The cells show a great variability in size and nuclear shape. Mitosis in letter M are seen, and there is a little evidence of mucin secretion. In growth characteristics of your surface neoplasms in your colon, this is a benign neoplasm of a villus adenoma and low power. It shows one form of a benign colonic neoplasm. This villus adenoma has grown into the lumen in the form of papillary fronds in letter F, with a stromal core covered by a moderately dysplastic epithelial cells. The underlying muscularis mucosa in letter MM is intact, and there is no downward tumor spread. Malignant neoplasms not only form a mass in the lumen, but also spread across the epithelial basement membrane into your subepithelial tissues. In letter B, of a colonic adenocarcinoma, these tumor cells in letter T have grown in complex abnormal gland formation in G within the mucosa. Malignant glands are also seen invading into the submucosa in letter SM, having breached the muscularis mucosa in letter MM and have spread beneath the adjacent normal mucosa in MUC. This is local invasion. In letter A, benign neoplasm of your myometrium in low power. Letter B is the margin of lesion in A, which is a medium power. In letter A, it shows a benign neoplasm of your uterine smooth muscle. A leiomyoma in letter L is surrounded by a normal myometrium. The tumor margin is shown at higher magnification in letter B. Note that the neoplasm is well circumscribed and shows no evidence of local invasion. This neoplasm has expanded symmetrically and compressed the supporting stroma of the myometrium to form a pseudocapsule in letter C. This is the malignant neoplasm of your breast in low power, and letter D, the margin of lesion in letter C, which is in medium power. In letter C, it illustrates a breast carcinoma. Take note of the neoplasm, which has an irregular outline with tongues of neoplastic cells invading the fatty tissue in letter FA, and the collagenous stroma and ST of the breast. There is no tendency to form a capsule here, and the ill-defined tumor margin is illustrated in 7.12D, which hyperchromatic malignant cells can be seen infiltrating the surrounding adipose tissue. This is lymphatic spread. In A, it's a tumor in a lymphatic vessel in high power. It illustrates a large valve lymphatic in LY containing an embolic clump of malignant tumor cells in T en route to a lymph node. Tumors spread via the lymphatics to regional lymph nodes is a very common mode of spread for carcinomas. In letter B, it's metastasis in a lymph node in medium power. It shows a lymph node draining a primary breast carcinoma. Tumor cells which arrive via afferent lymphatics lodge and proliferate in the subcapsular sinus in letter S. From here, the malignant cells may then infiltrate down the medullary sinuses in MS and go on to form solid masses in the parenchyma of the node, which is not illustrated here. This is hematogenous spread of malignant neoplasms. In letter A, that's malignant colonic neoplasm in medium power. In letter B, that's malignant breast neoplasm. In A, it shows a large serosal vein from a colon in which there was an extensive malignant neoplasm. A solid mass of tumor is growing along the vessel of your lumen. The site of invasion of the vessel wall was proximal to the section and therefore cannot be seen. In letter B, it's a venous invasion by carcinoma of the breast. Solid masses of tumor cells in letter T infiltrate the fatty tissue of the breast, where tumor emboli are seen within 3 small venules in letter V, and also 2 small lymphatics in letter L, which are adjacent to a nerve in letter N. The arterioles letter A, close by are not affected. Vascular and lymphatic invasion by tumor is an important factor in the prognosis of many types of tumor. This is transcoelomic spread of your malignant neoplasms in high power. This is an example of a smear of ascitic fluid from a patient with metastatic breast carcinoma. The tumor has spread through the pleural space, and it reached the peritoneum, probably via the diaphragm. Aspiration of the fluid serves to relieve symptoms and to confirm the diagnosis cytologically, or we call it diagnostic paracentesis. This is a metastatic tumor deposit in solid organs in liver in medium power in letter A, and letter B is a long and low power. As noted above, metastatic deposits of tumor are frequently encountered in liver, lung, bone marrow, and brain as a result of hematogenous spread. Other tissues are less common sites for deposition of metastatic tumor, example a heart and skeletal muscle. Hepatic metastases often arise from organs drained by the portal system. The lesion in A is from a moderately differentiated adenocarcinoma of the colon. Lung metastases, on the other hand, arise from a tumor emboli from the systemic venous circulation, and letter B is an example of a secondary spread from a primary breast carcinoma. Note that both of the tumors have included a stromal reaction in the form of fibrous connective tissue containing blood vessels and inflammatory cells. This is perineural spread in high power. Spread along the course of the nerve bundles is a common feature of some tumors such as the adenocarcinoma of the prostate, but may also be seen in other tumor types. In this figure, it shows a perineural invasion by a well-differentiated prostatic adenocarcinoma. In letter T, this is tumor cells in a glandular conformation which are seen infiltrating around and between bundles of your nerve fibers in letter N. This is uterine cervix in H and E and low power. The uterine cervix, as you know, is protruding into the upper vagina and contains the endocervical canal linking the uterine cavity with the vagina. The function of your cervix is to admit the spermatozoa into the genital tract at the time when fertilization is possible. Example, around the time of ovulation. At other times, including pregnancy, it is important to function to protect the uterus and upper tract from bacterial invasion. In addition, the cervix must be able of great dilatation to permit the passage of the fetus during parturition. This is your skin architecture. In this diagram, it shows the basic structure of your skin with the three component layers: the epidermis, the dermis, and the subcutis. The surface layer is in contact with the exterior, which is the epidermis in letter E. A highly specialized self-regenerating stratified squamous epithelia, which produces a non-living surface rich in a protein, keratin in letter K, which is tough and protective and is also partially water resistant. This is a stratified squamous epithelium, letter H diagram, letter B in high power, letter C in medium power, and letter D is a Papanicolo smear. The stratified squamous epithelium consists of a variable number of cell layers that exhibit maturation from a cuboidal basal layer to a flattened surface layer. The basal cells, which are adherent to the underlying basement membrane, include continuously dividing stem cells, their offspring migrating towards the surface, where they are ultimately shed as enucleate squames. Stratified squamous epithelium is adapted to withstand abrasion with plentiful cell junctions and a prominent intermediate filament, which is keratin cytoskeleton. This type of epithelium lines your oral cavity, the pharynx, your esophagus, the anal canal, uterine cervix, and the vagina. These sites, which are subject to mechanical abrasion but which are kept moist by glandular secretion, such as your salivary glands of your mouth. This is a transitional epithelium in A, that's a diagram, and letter B, that's an H and E in high power. The transitional epithelium or your urothelium is a form of stratified epithelium found only in the urinary tract in mammals, where it is highly specialized to accommodate a great degree of stretch and to withstand the toxicity of urine. The epithelial type is so named because it has some features intermediate or the transitional between the stratified cuboidal and stratified squamous epithelia. In the non-distended state, the transitional epithelium appears to be about 4 to 5 cell layers thick. The basal cells here are roughly cuboidal, the intermediate cells are polygonal, and the surface cells are in umbrella or dome cells in letter U in arrow. They are large and rounded and may contain 2 nuclei. In the stretch state, the transitional epithelium often appears only 2 or 3 cells thick, although the actual number of layers remain constant, and the intermediate and surface layer are extremely flattened. These are simple tubular glands in letter A, that's the diagram, letter B, that's H and E in low power, and C, it's medium power. Example of this simple tubular gland is taken from your large intestine. This type of gland has single, straight, tubular lumen into which the secretory products are discharged. In this example, the secretory cells line the entire duct. The secretory cells are the goblet cells. These glands are shown in longitudinal section in the micrograph in letter B and in transverse section in letter C. They emphasize the regular arrangement of the glands and the large number of mucus-secreting goblet cells in the epithelium. At other sites, mucus is secreted by columnar cells that do not have the classic goblet shape but nonetheless function is in a similar manner. Simple branched tubular glands. In diagram letter A, this is a low power in H and E. The simple branched tubular glands are found mainly in the stomach. These mucus-secreting glands of the pyloric part of the stomach are shown in this example. Each gland consists of several tubular secretory portions, letter T, which converge onto a single unbranched duct, letter D, of a wider diameter. Mucus-secreting cells also here line the duct, but unlike those of the large intestine, these mucous cells do not have a goblet shape. This is sentinel lymph node biopsy. We discussed the mechanism of this treatment. One common route of your cells, cancer cells, via the lymphatic system to local or regional lymph nodes. Cancer typically spread in a predictable fashion to local nodes before involving distant nodes. So we have lymph node clearance. We call it lymphadenectomy of all the regional nodes in the vicinity of a tumor can result in a significant morbidity for the patient due to lymphedema. The sentinel node procedure is aiming to reduce this morbidity by identifying those patients with pathological evidence of lymph node spread and offering only these patients completion of lymphadenectomy. The sentinel lymph node biopsy, or SLNB, can also be used to stage patients with advanced disease. So in this next diagram, you will see the regional lymph nodes, the tumor, extract it, the sentinel lymph nodes, and using a probe, remove the tumor and collect the sentinel lymph nodes. This is your SLNB. This is liver metastasis. There are multiple pale circumscribed tumors of varying sizes throughout this liver parenchyma, representing the metastatic tumor deposits. And also, common sites of primary origin for this appearance would include the colon, the breast, the lung, and the upper gastrointestinal tract. We have also pulmonary metastasis. The multiple wide circumscribed nodules are seen in this section of your lung, in keeping with the metastatic tumor deposits. And that's the dysplasia and neoplasia. Up next is the atherosclerosis for the medical histology or pathology laboratory. Thank you so much for watching, and don't forget to like and subscribe this YouTube channel. Have a nice day. Thank you.